and that. Assalamu alaikum, everyone. It comes as recording in progress. When I say continue, okay, now it's, I think it would be fine. It was saying recording in progress and then it would cut me off. I apologize for that. Again, let's start with everything is, can you hear me?
Yes, yes.
Okay. Sorry for that hiccup as I actually had to come to New York City for an emergency in my family, and I'm calling from here. So there's a little bit of Wi-Fi problems and all that, but hopefully it won't interrupt anymore. So I was saying thank you, Dr. Flanagan and Dr. Faisal Sultan from Pakistan, Special Advisor to the Prime Minister on Healthcare. As most of you know here about APPNA-MERIT, APPNA is an organization of Pakistani physicians in North America, US and Canada, that was founded about 44 years ago. And since then, it has done many projects. It started as a social network for the people away from their homeland and adopting to the new land and new home. But along the way, we picked up many projects for Pakistan, for here, advocacy, philanthropy, medical education, and all that. And this committee of APPNA-MERIT was founded in 2007, and it has done a lot of work, but in particular in the past few years, and I don't want to take the full credit for me. I was the chair for 4 years, and this year, Dr. Danish Bhatti is the chair. I'm co-chair, but the team is the same. Dr. Nahid Usmani, who started this and founded this committee, is still with us. Dr. Babar Rao has been chair and still with us. So the core team of working member, and Fizza Gilani is with us for many years. Fizza Rafiq is with us for many years. So we have, I think the success of APPNA-MERIT is because we have the continuity and the core team, and it's ever expanding. We have worked with many institutions in Pakistan. We have worked with the Higher Education Commission, different various universities, health ministry, federal health ministry, and provincial health ministries, as well as CPSP, and introduced many fellowships. Obviously, we cannot take credit for everything. I think the main thing is done by the great minds and leadership like Faisal Sultan in Pakistan. We just collaborate, we guide them where the guidance is needed, we work where work is needed. But obviously the main thrust of any medical research project and disease-specific projects such as HIV is done mainly in Pakistan, and tremendous, talent and hard work there in our homeland. We just want to collaborate. We learn from our colleague in Pakistan. We appreciate their guidance and advice, and it's a mutually beneficial academic activity. And along the way, if we can make a difference in common people's life, common patients in Pakistan. So that's the mission and direction of APPNA-MERIT. Sometimes we pick up a theme for the year. Last year it was family practice. This year it is research and healthcare innovation in Pakistan. And we are running a series of webinars along that. And we are very excited that this series has been very popular. Every Saturday we run a webinar with a different leadership and institution in Pakistan and learning from them where is the status of research and healthcare innovation in Pakistan, and how can healthcare diaspora can participate in that monetarily, academically, in person with the time, any capacity. So that has been very successful, and we hope that we will have an in-person conference in December in Pakistan to conclude that and to meet all those leaderships in Pakistan in person. Hopefully COVID by that time should be behind us. And along with that, other thing that APPNA has started is online courses. APPNA-MERIT has been very successful in developing many courses, and they are available in APPNA Academy. So some are in neurology, some are in other fields like bedside testing for point of care ultrasound focus is a course available there. Movement disorder in neurology course is available there. Stroke course is a lengthy course, 9-month course, and it's ending this July, and it was very successful. In addition, we are now developing a course for research methodology and all that. Of course, there are many courses available already in Pakistan and online, but I thought we can bring a different angle, and people can learn from different sources the same thing, and whichever source they like, it should be available to them. So with all that introduction of APPNA and APPNA-MERIT and different committees, I would like to invite the APPNA-MERIT Subcommittee on HIV. So this is another thing that we did, because the medical education and research is so broad that the chairs and co-chairs of APPNA-MERIT cannot handle them efficiently and justify it to the great work of different subcommittees. So ER is one. We started with Junaid Razak, and nephrology and neurology and cardiology with Dr. Motin. Pulmonology and critical care is a very active. ICU committee is very active. So all these subcommittees are very active. And now this is a new committee, although Dr. Fizza Gilani has worked a lot in the past for HIV. So it's not new for them. The work is not new for them. But from this platform of APPNA-MERIT, I think it's the first time that a more robust committee has been formed. And thank you for the Brown faculty who have done tremendous work on HIV to work with us and with Dr. Fizza Gilani on this important new initiative of APPNA-MERIT. And so with that, I will invite Fizza Gilani. She's the committee chair for HIV. She's an associate professor of medicine and research at Alfred Medical School of Brown University, Department of Medicine, Division of Infectious Disease. Her role as faculty member is to guide the junior faculty, ID fellows, residents, and medical students in their research projects. Her area of interest is public health research with a specific focus on HIV, AIDS, and medical information in diagnostic and international setting. So please welcome Dr. Fizza Gilani. Thank you for joining us. Please go ahead and tell us about your committee and your mission and statement and what your goals are.
Many thanks, Dr. Shahid Rafiq. I appreciate your kind words. Hello, everyone. And I welcome you all to this inaugural session of the HIV Awareness, Prevention and Education Project in Pakistan, designed and led by the APPNA-MERIT HIV Committee. The APPNA-MERIT HIV Committee is a group of professionals working in the fields of HIV, infectious diseases, and internal medicine in the USA, with the goal of helping Pakistan control its HIV epidemic. We all are very proud to offer this volunteer academic activity service. And to do this project, our group has partnered with the Government of Pakistan CMU group and the Medical Microbiology and Infectious Diseases Society of Pakistan. The HIV in Pakistan project activities are based on specific aims. First aim of this project is to conduct this series of webinars to initiate conversations between key stakeholders from Pakistan and members of the Pakistani diaspora working in the USA, UK, and other countries. Today's webinars is the first of this series of 7 to 10 HIV webinars. At the end of these, or at the end of all these webinars, or to conclude aim 1, the committee will create an official white paper detailing all practical suggestions, interested institutions, possible collaborations, and projects. Second aim of this project is to use the information from these webinars to create a basic HIV 101 course catered for general practitioners, healthcare providers, and medical students in Pakistan. And aim 3 and beyond will involve several smaller projects, including translations of this HIV 101 course in different local languages of Pakistan and exploring HIV clinical trial options in Pakistan. We invite all healthcare institutions from Pakistan and all interested groups abroad to join this initiative to address this neglected disease. Please let us know if you have any specific topic or specific project in mind and if you would like to join our group. Also, please write your questions in the QA box and your comments in the chat box to help to broaden the understanding of HIV disease in Pakistan. Finally, HIV team introduction will not be complete if I do not mention my dear colleagues from the Department of Medicine, Division of Infectious Diseases at the Alpert Medical School of Brown University, Rhode Island, USA. This is a group of about 28 ID HIV physicians who have been supporting HIV in Pakistan project ever since it started. This is a group who kept sending me any new published research paper, newspaper article, or news clips about HIV in Pakistan from last 19 years. I would like to call my Brown University colleagues as honorary members of the APPNA-MERIT HIV Committee. Thank you very much, Brown University ID Division and Providence Boston Center for AIDS Research. Also, special thanks to APPNA-MERIT leadership who created this new APPNA-MERIT HIV committee this year. Together, we all can help people living with HIV in Pakistan and other areas of the world. Before I start, I want to post a question to everyone listening in this webinar today. This question is directly linked to the reuse of needles in healthcare settings in Pakistan. So question is, how long you think HIV virus can survive in a syringe or tube on a room temperature? I'll repeat the question again. How long HIV virus can survive in a syringe or in a tube in a room temperature? If you know the answer, please write your answer in the chat box. We will announce the winner of this question answer next week. Thank you very much. And this is all from me. And many thanks for joining today's webinar.
Thank you, Dr. Fizza Gilani. I think this committee, this initiative is great. This committee, I know most of the members, they are great leaders and workers. And I'm sure with the Brown collaboration and with the Pakistan team, I think I know most of them as well. This will do great. So next is Dr. Fizza Zahid Rafiq from Calgary, Canada. She's going to tell us about the HIV/AIDS. And Fizza is a medical graduate from Fatima Jinnah Medical University, Lahore, Pakistan, and currently working in Calgary, Canada as a family physician at Trans-Canada Medical Center. She's a clinical faculty at University of Calgary, involved in teaching medical residents and students. She's a lifetime APPNA member, and also the member of MD International. And she's the current president of Fatima Jinnah Medical University alumni in Apna. So Fizza, Rafiq, please go ahead.
Assalamu alaikum, everyone. Thank you, Dr. Shahid Rafiq, for your kind introduction. And as Dr. Shahid Rafiq said, I am working as a family physician in Calgary, in Canada. And before coming to Canada, I was working in South Africa. For 2 years, I worked there in obstetrics and gynecology. And then I did my family medicine rotations in pediatrics and urology and internal medicine. And I have seen lots of HIV patients there, and as well as full-blown AIDS patients too in internal medicine. And we had treated those patients as well. And now in Canada, I have few patients with HIV in my clinical practice. So today's topic that is given to me to present is HIV in a nutshell. So next slide, please. So I have no actual or potential conflict of interest in relation to this program or presentation. So goals of this presentation is to reduce the stigma and increase awareness about HIV/AIDS disease by empowering healthcare providers, patients, and communities in Pakistan. And the objectives are to discuss different aspects of HIV/AIDS disease, including disease progression, stages, types, symptoms, and transmissions mode in general and specific in Pakistan culture, understand the myths about HIV/AIDS disease to reduce stigma about the disease, and understand the facts about HIV/AIDS disease in general and in Pakistan. So where did HIV come from is an interesting history that I wanted to share with all of you. HIV infection in humans actually came from a type of chimpanzee in Central Africa. The chimpanzee version of the virus is called simian immunodeficiency virus, or SIV, and was probably passed to humans when humans hunted these chimpanzees for meat and came in contact with infected blood. So studies show that HIV may have jumped from chimpanzees to humans as far back as the late 1800s. So over decades, HIV slowly spread across Africa and later into other parts of the world. And we know that the virus has existed in the United States since at least the mid to late 1970s. What is HIV? Human immunodeficiency virus was identified in late 1970s or 1980 and is from a group of viruses. Those are called retroviruses. HIV is a virus that spread through certain body fluids, including blood, genital fluids, and breast milk, that attacks the body immune system, especially the CD4 cells specifically, and often called T cells. And these special cells help the immune system to fight infection. If left untreated, HIV reduces the number of CD4 cells in the body, and this damages the immune system, makes it harder and harder for the body to fight off infections and other diseases. Now, just wanted to give you a little bit of information about HIV epidemic in Pakistan. So in 2019, a completely new HIV landscape, it was there as a global spotlight when around 1,175 people, including 935 children under 12 years of age, were diagnosed with HIV, and they were positive between April 25th to November 9, that was in 2019, in Sindh, Pakistan, followed by similar reported cases in other parts of the country. HIV in general, according to the latest statistics from the Centers for Disease Control and Prevention, around 36.7 million people are living with HIV source around the world. While there have been many advancements in the management of HIV virus throughout the years, unfortunately, a lot of misinformation still exists about what it means to live with HIV. Over 68,000 individuals are currently living with HIV in Canada, and in the United States, approximately 1.2 million people are currently living with HIV. So what are stages of HIV? There is a myth that every person who has HIV has AIDS. Actually, that's not true. There are different stages of HIV. There are 3 stages of HIV. Stage 1 is acute HIV infection. People have a large amount of HIV in their blood. They are very contagious, and some people have flu-like symptoms, and this is the body's natural response to infection. Some people may not feel sick right away or at all. And if you have flu-like symptoms and you think you may have been exposed to HIV, then you have to seek medical care and you have to ask to test yourself and to get diagnosed for acute infection. Next slide, please. Stage 2 is chronic HIV infection. This stage is also called asymptomatic HIV infection or clinical latency. HIV is still active, but reproduces at very low levels, and people may not have any symptoms or get sick during this phase. Without taking HIV medicine, this period may last a decade or longer, but some may progress faster. People can transmit HIV in this phase. At the end of this phase, the amount of HIV in the blood called viral load goes up, and the CD4 cell count goes down. The person may have symptoms as the virus levels increases in the body and the person moves into stage 3. And people who take HIV medicine as prescribed may never move into stage 3. So this is why it is very important to start the medications as soon as possible you get diagnosed with HIV. Stage 3 is actually what is called acquired immunodeficiency syndrome and AIDS. It's the most severe phase of HIV infection, and people with AIDS have such badly damaged immune system that they get an increased number of severe illnesses, which are called opportunistic infections. People receive an AIDS diagnosis when their CD4 cell count drops below 200 cells, and if they develop certain opportunistic infections. People with AIDS can have a high viral load and be very infectious. And without treatment, people with AIDS typically survive about 3 years. So this is a slide that shows the HIV progression. So before HIV, and then that's the acute stage, then in the chronic stage, and full-blown AIDS when the CD4 cell count drops quite a bit, and the viral load is very high. Now, what are symptoms of HIV? Some people have flu-like symptoms within 2 to 4 weeks after infection that is called acute HIV infection. And these symptoms may last for a few days or several weeks. Possible symptoms include fever, chills, rash, night sweats, muscle aches, sore throat, fatigue, swollen lymph nodes, and mouth ulcers. But some people may not feel sick during acute HIV infection, and these symptoms don't mean you have HIV. Other illnesses can also cause these same symptoms. So it is very difficult in the acute stage to diagnose yourself or to find out whether you have HIV or not. In some patients, this illness is so mild that it passes without being noticed, and some people mistake it for flu. But for some people, it is more severe, and they may need to see a doctor. However, because the symptoms are like symptoms of many other conditions, HIV might not be diagnosed at that time. So if someone had a high-risk contact and notices these symptoms about 2 weeks later, and providers might want to consider having an HIV test on them. So modes of transmission of HIV is iatrogenic procedures, shared contaminated needles, or any instruments used by healthcare providers. It can be reuse of disposable needles or IV drips that are used in Pakistan. These are the common modes of transmission which were identified in Pakistan. So shared needles by injected drug users, shared crack cocaine users, snoring instrument, blood transfusions, contaminated blood with HIV used for transfusion, shared contaminated razors within a household, shared contaminated shaving blades by barbers or beauty parlors, contaminated unsterilized instruments used by dentists, contaminated instruments used by midwives, unsafe sex with any HIV positive person includes sex trade, MSMs, and others. Mother to child transmission is a very common question really that comes around whether people can get pregnant when they have HIV or what will be the risk. So HIV can be transmitted from mother to child during pregnancy, at childbirth, or during breastfeeding if mothers have a virus. But if they're taking the treatment, there's a very low risk of transmitting the virus to the baby. So yes, they can still get pregnant, but it's very important to take the treatment during pregnancy, and at the time of delivery, there's a very little risk of transmission. Next slide, please. Now, myths and facts. So lots of myths about HIV, that how it is spreading, and should we contact the patients who are HIV positive, and really people, when a diagnosis comes with HIV, it's like a death sentence to many people. So this is what we need to create awareness about HIV. The HIV cannot be spread through saliva, through sweat, through tears, casual contact such as sharing food utensils, towels, and beddings, swimming pools, using same telephone sets, toilet seats, biting insects such as mosquitoes, hugging any person who has the disease, shaking hand with any person who has the disease. So it's not going to spread by any of these modes. Need to create increased awareness during provided patient encounters. When a patient comes to you, you have to keep yourself, patients, and families calm about HIV disease. Treat the patient with respect. Do not discriminate the patient based on disease. Show empathy, be sensitive to their emotions. They can be very, very sensitive. They might be going through depression. As I said, it can be a death sentence to many people, and they will be thinking that they might be judged that they have HIV. So we need to show empathy, and we don't need to discriminate them. Tell them you're here to help the patient and family. HIV treatment is free in Pakistan. We have to discuss these options and train the providers and patients about the optimal treatment. So these are the references. Few of the references I could put on these slides were taken from National AIDS Control, HIV/AIDS Center for Disease Control and Prevention, and then WHO Clinical Staging System of HIV and AIDS. So thank you so much for giving me an opportunity to talk to you today and discussing some of the myths and facts of HIV.
Thank you, Dr. Fizza, Zahid, Rafiq. It was very informative overview. And now I think we probably Dr. Flanagan's presentation, we dive a little deeper into it. But before that, we would like to listen from our colleague and very well-respected leader in HIV in Pakistan. And this whole collaboration will be done with her leadership and of course, the government health sector. And that's Professor Bushra Jamil. She is going to talk about history of HIV in Pakistan. Dr. Bushra is a national coordinator of Common Unit for Management of HIV, TB, Malaria grants, and Ministry of National Health Services Regulation and Coordination, Ministry of National Health Services Regulation and Coordination in Pakistan. She's also president of Medical Microbiology and Infectious Disease Society of Pakistan. She's a consultant infectious disease at Aga Khan University. And I think she's moving to a bigger leadership role. And you can share, Dr. Bushra, about that if I missed that. But please welcome Professor Bushra Jamil.
Thank you very much for your kind introduction. So if I can share my screen now. So is the presentation visible?
You're muted.
I was muted. Dr. Bushra.
Can you, yeah.
Yes, now we can see it.
Okay.
Yes, go ahead.
So I'm going to talk about history of HIV in Pakistan. So the first cases of HIV were noted in the late 1980s, and these were seen in people who were returning from the Gulf countries. So repatriated migrant workers were the first ones who brought HIV to Pakistan. In response to the influx of these cases, National AIDS Control Program was launched in 1986 to 87. And since then, we've had a sort of non-continuous surveillance. And this has indicated that HIV prevalence was high in certain populations in Pakistan. And gradually, since the late 1980s till now, Pakistan has moved from low prevalence, high risk country to a concentrated epidemic, which means that the prevalence is more than 5% in certain key populations. According to estimates in 2016 to 2017, 38.4% cases were found in people who inject drugs, 7.2% in transgenders, 5.6% among men who have sex with men. So what kind of mindset do we have? So we are in a state of continuous denial. And whenever we discover HIV cases in any part of Pakistan, we call it an outbreak. So, and behave as if this is rather sudden or unexpected occurrence of a disease which we do not expect to see in our population. So we have been seeing clusters of cases here and there, and it is plausible that HIV is endemic in parts of Pakistan, which have been labeled as hotspots in publications, and that at the moment it is actively spreading to many different parts of the country. So this map here shows you 3 hotspots which have been identified from the year 2000 onwards. So there have been 7 notable outbreaks, 3 in Sindh, 4 in Punjab, and 4 have been identified since 2016. So there is 1 hotspot in Gujarat and adjacent areas, 1 in Sargodha and adjacent areas, and 3rd one is in Larkana. This is just a timeline of different outbreaks which has been published. So starting off from first major outbreak in 2003 in Larkana, where 175 people were screened. This was followed by another one in Gujarat, Punjab, where both adults and children were found to be positive. This was in 2008. Then again in Larkana in 2016. This was in dialysis patients, and in the same year, another outbreak was identified in Chiniot, Punjab. Then in 2018, again, 2 outbreaks were described, one in Sargodha, another one in Dera Ghazi Khan. And then from 2019 onwards, there have been a few more outbreaks, one in Sargodha, the other notable one in Ratodero, and so on. So since the inception of the National AIDS Control Program and subsequent devolution of health, according to the 18th Amendment, there is an absolute need to take stock of HIV funding and where and how it was spent. So there has been a clear failure in containment, and the common factors are being identified repeatedly. The factors which lead to these outbreaks have been identified repeatedly, and they're similar in most of the outbreaks. It has been noted in one survey that approximately 38% GPs reuse syringes, and iatrogenic transmission from unsafe practices and poor infection prevention and control have been identified as primary or contributing risk vectors in 5 out of 7 major outbreaks. First one in Jalalpur Jatta in 2008, then Larkana, then in other parts of Pakistan. Since 2019, 3 outbreaks have been reported, a large one in Ratodero, another one in Sargodha, and another one in Faisalabad. And the one in Faisalabad was in people who inject drugs. The other 2 were because of poor IPC practices. So let's take a look briefly at these prominent outbreaks. The first one from Jalalpur Jatta, this was in 2008, when an NGO arranged 2 voluntary HIV screening camps when they observed rising number of HIV cases. And in this outbreak, it was found 246 persons were screened, and unsafe injections were found to be responsible in 96% of cases, dental procedures in 40%, barbershop visits in 72%. These were the most common risk factors. Additionally, extramarital sex was reported by nearly 10% of individuals, and nearly 4% had admitted to paid sex. In Gujarat district, infection has been believed to be endemic for over a decade, silently, and the transmission has continued to adjacent areas. So although forgotten and not news anymore, the next generation of affectees are still presenting with AIDS to different physicians. So unlike other studies from Pakistan, a high proportion of cases in Jalalpur Jatta were in females and children less than 10 years of age. And at that point in time, it was observed that the shift is taking place from high-risk groups to general population. Phylogenetic analysis was also carried out, and it revealed that the infection, the HIV belonged, the strain belonged to subtype A, and this transmission has been taking place for over a decade, and the situation was in fact endemic rather than an outbreak. So looking at this map of Sargodha and adjacent areas, Sargodha is considered to be a hotspot of HIV infection. And again, this is related with malpractice by quacks. This has been identified as a major factor. Then we move to Larkana. Now, Larkana has been a hub of HIV, and there have been many, many outbreaks in Larkana since 2003. So in 2008, results of round 3 of National Surveillance Program showed that nearly 28% Hijra sex workers were HIV positive in Larkana. Since 2005, IV drug users have been driving the epidemic in Larkana, and multiple surveillance rounds have shown a lower prevalence of HIV among commercial sex workers compared to IDUs. And this was especially true for Larkana. So HIV positive IDUs had more than 2 commercial sexual encounters as well. So this was not just spreading in isolation in just IDUs, but because of their encounters with the professional sex workers, this started spreading in the sex workers as well. For Larkana, it has been said that a small town of over 500,000 population has surpassed a large metropolis like Karachi of almost 20 million persons in risky practices. So this is an unusual town with an unusual pattern of multiple commercial sex activities happening there. So Larkana has a functioning brothel where clients from all over the district and from other cities visit sex workers in the daytime. Additionally, there are home-based sex workers as well, and there are at least 2 musafir khanas or motels right in the center of the city where Hijra and male sex workers are available round the clock. So the city had all the characteristics of an exploding HIV epidemic for the last 20 years, and this is not something new. So from 2004 onwards, it was observed in many different publications that Larkana might be at the brink of an HIV outbreak in low-risk groups. And concerned stakeholders must look into this pattern urgently and take prudent measures, such as improving quality, services, and more importantly, coverage of HIV prevention programs. So whatever has happened in Larkana has been happening for the last at least 20 years. Then we should take a look at the role of blood transfusion and transfusion services in HIV spread in Pakistan. So going back to 2014, this was reported in Dawn. At least 10 children between the ages of 5 and 16 already afflicted with thalassemia tested positive for HIV after allegedly receiving transfusion of infected blood. So in response to this news, in-depth investigations were carried out by Punjab AIDS Control Program along with National AIDS Control Program. And the investigation revealed insufficient evidence to support the reported epidemic. However, Punjab AIDS Control Program, with the support of donors, undertook an extensive screening of thalassemia children in the province. The results were not publicized, so we don't know what happened with that investigation. So the blood transfusion system has been said to be weak, fragmented, and mostly unregulated. This was the situation in the mid 2015 and up to 2015. With an estimated 2.8 million bags transfused in the country every year, with uncontrolled and unregulated screening for transfusion transmitted infections, the chances of spread of bloodborne infections are very high. This was 2014. In September 2016, an outbreak was identified at Civil Hospital Larkana in dialysis patients. And of all the screened dialysis patients, which were 205 in number, approximately 43 were HCV positive, 29% were HIV positive, and 20% were both HIV and HCV positive. So the question arose, was this spread related to poor or non-existent disinfection of equipment or hemodialysis machines? Or was it due to transfusion of unscreened blood, or both? So amid these suspicions, investigation was launched. And actually, the paramedics and dialysis unit workers were investigated as to why they were giving unscreened blood and what was going on at the dialysis center. And the health ministry was activated, and they went around talking to people. So the healthcare workers were probed. The Sindh Blood Transfusion Authority, it was suggested, should also be included in the investigation, with focus on its inability to monitor and take action against the blood banks involved in illegal business. This was from the health minister at that time of Sindh. And 4 illegal and ill-equipped blood banks and laboratories were sealed. Dialysis center was closed down, and patients were moved to other centers in different parts of the province. Actually, what happened was that there was no formal process of referral, and infected patients moved to other equally unequipped centers in the province. Many came to Karachi, but many of them ended up in other dialysis centers in poorer parts of Sindh. So the issue was resolved, and responsibility was fixed on the perpetrators, that is those who initiated the screening process in this case. The blood banks, which were sealed, reopened after a few days, and the practices continued. So in 2014, the then President of Pakistan affirmed his commitment to continue and increase efforts to respond to HIV in the country. So this was a political statement, and without a follow-up plan. So there have been 3 strategic plans, and what has been their focus? First National Strategic Framework in 2001 culminated in establishment of first response called Enhanced HIV and AIDS Control Project, and this ended in 2008. Second framework focused on interventions in key population, and the third strategic framework from 2015 to 2020 focused on quality HIV treatment and care services. After devolution in 2011, the provinces mobilized their own resources, and they've been used mainly to prevent infection from establishing in key populations. At this point in time, in 2011, federal government released funds for the purpose to help provinces deal with this situation, but the funds were released to Punjab only. And major reliance was on global funds and UNAIDS grants. So the reasons for rise of HIV in Pakistan are known. Important questions are how to contain this epidemic, how to ensure quality services to those who are already infected. And it's time for action now. Actually, we are quite late because all our previous strategies have failed. Thank you very much.
Thank you, Dr. Bushra Jamil. It was an excellent presentation. We learned a lot about Pakistan in the, how the HIV status at current status of HIV in Pakistan. Now I come to our speakers for today. I don't know if Dr. Nosheen Hamid will join us. So we have 2 speakers if she's not here. First will be Dr. Flanagan, and final speaker will be our chief guest, Dr. Faisal Sultan. So let me invite Dr. Timothy P. Flanagan. He's a professor of medicine in the infectious disease division of the Miriam and Rhodes Island Hospitals and Brown Medical Center. He received a BA from Dartmouth College and MD from Cornell University Medical School. In 1991, he came to join Dr. Charles Carpenter to lead the HIV and AIDS program and was subsequently appointed Chief of Infectious Disease in 1991, and he served there until 2012. He spearheaded the HIV care program at the Rhode Island Department of Corrections to develop improved treatment for HIV infection and has received NIH and CDC funding for over past 30 years. He received the Robert Wood Johnson Foundation Community Health Leadership Award in 2000. Currently, he's co-directing the new Lifespan Lyme Disease Clinic. His topic for today's talk is HIV epidemic in the world, role of developing world to control future transmissions, and how developed countries can help. So this is exactly what we are talking about today, a collaboration between a developed country such as the US and Canada, and particularly Brown University leading this effort, and Pakistan and Pakistani's healthcare providers, as well as the leadership. So welcome, Dr. Flanagan. Thank you for joining us.
Thanks, Dr. Rafiq. And both of these talks have been really great. I mean, both, it's an excellent overview initially, and then really to see the challenges in Pakistan is very, very helpful to think how we might respond. I'm going to start with the story of a patient of mine. I've been doing HIV care for 30 years, and I've also helped collaborate in other countries, including Ghana, Kenya, and Southern India in responding to the epidemic. But I want to bring it back to the personal level and start with a patient I saw last week, John. I still do HIV care. I've been taking care of him for 20 years. He's a difficult patient without any family support at all. And I met him in the HIV clinic in our state prison 20 years ago. One of the key take-homes in this presentation and one of our key challenges is how do we implement testing in a routine way that provides support and does not stigmatize? We've been fortunate that we've been able to have routine offering of HIV care within our correctional setting with the provision of HIV care, and it's worked quite well. And there have been huge successes with the routine offering of HIV care among pregnant women and among other risk groups, but also among others that we don't consider risk groups. I mean, certainly no one would consider a dialysis patient to be a risk group. No one would consider a patient with bad pneumococcal pneumonia or zoster or shingles to be a risk group. But yet the importance of routinizing, making HIV testing part of good medical care is so key. So he was initially diagnosed 20 years ago there, and I saw him in a weekly clinic, and then we were able to take care of him on the outside. What's extraordinary is that even though he's a difficult patient without much good family support, his viral load has been non-detectable for 15 years. So how this happened, I think, is so instructive for us. Now, when he left prison, he did not think this was going to be the case. He really did not have hope. He did not think he could beat HIV. He didn't think he'd be able to come to our clinic. You know, if you're someone who's been on the edges of society, you don't think you can always go to a regular clinic. How will they treat you? Will it work well? Will they tell everybody about your situation? He didn't think he was welcome. He didn't think that he could control this infection. He had known so many people that had become sick and died, and he thought that really he had no hope. And what we found was linking him to care and being able to provide HIV care gave him that hope and started to make that difference. So as I say, I started HIV care. My first patient I took care of was in 1983 in New York City. At that time, we had, of course, no treatment. We didn't even know that the HIV virus caused the disease. So there really was no hope. And those early years of the epidemic were very, very, very heartrending. Between 1988, when AZT was introduced, and the year 2000, we saw the development of very effective antiretroviral therapy. Sometimes we call it HART, highly active antiretroviral therapy. Sometimes we call it CART, C-A-R-T, combination antiretroviral therapy. But treatment for HIV is truly one of the great successes of modern medicine. Imagine, to me, this is similar to the successes in treating children with leukemia. A child diagnosed with ALL, acute lymphocytic leukemia, before we had good chemotherapy, was a 90% fatal disease. Today, it's a 90% cure. It's just incredible to see. I think our HIV therapies are easily that effective. It's not a cure, but the ability to drive the viral load down to non-detectable, the ability of the body to recover its immune function. I've taken care of so many patients that have come to see me literally bedridden on a cot, often with multiple opportunistic infections. And yes, those opportunistic infections have to be treated, but really it's combination antiretroviral therapy, or ART, that has been extraordinary, really miraculous in what it's done. Now, once we got good ART, there was an enormous amount of skepticism. And I find that skepticism is still present today. Many of my colleagues said early on, oh yes, well, these are good medicines, but look at resistance. Resistance is going to be terrible. It will never keep working. Those predictions are wrong. Resistance is an issue, but it's been a very small issue. Our patients that die of AIDS do not die with resistant virus. No, they die with very high levels of circulating virus because they never took their ART at all. So resistance is a challenge, but it has not been a significant challenge. Combination ART has overcome it. Next is adherence. I remember discussions in 2002 where many of our colleagues said, oh, well, combination medicines work so well in the West, but they'll never work with a very poor family that only has one meal a day, that's chronically undernourished. They were totally wrong. We found that in every setting, including some of the poorest countries in Africa and other communities in Asia, I've collaborated with colleagues in Vietnam, some very, very poor communities, that the combination ART once a day has been incredibly effective. And in fact, many patients there will take it even better than they take it here in Providence, Rhode Island. They'll pull together, help each other out, and that can make an enormous difference. Others have said, well, what about side effects? Yes, there are side effects, but they are so manageable, and they are less than the side effects of our TB drugs. They are less than the side effects of our anti-seizure medications. They are less than our side effects of diuretics and treatment for congestive heart failure and bad COPD. These side effects are very, very, very manageable. So we've been able to provide ART, and the hope that that has been given is incredible. Now, many people early on said, oh yeah, but you can't give ART without laboratory monitoring. That wouldn't be appropriate. Look at the protocols. You need to know the CD4 count. That was the concern. That concern is wrong. You can give ART without laboratory monitoring, and specifically without CD4 count testing. So many patients have died of HIV and AIDS waiting for their CD4 count. Yes, if the CD4 count is under 200, we always recommend Cotrim or trimethoprim sulfa, Bactrim, Dapsone, good PCP prophylaxis. Yes, we always worry about tuberculosis. It's such a common co-infection. But I don't care if the CD4 count is 600, 400, 200, or 50. ART is absolutely critical. If it is very low, we might see IRS, immune reconstitution syndrome. Yes, we'll need to treat that. But ART is life-saving. And even with no monitoring, it can be given. We always worry about tenofovir and impairments of renal function, but actually compared to other medications we give, it's quite mild. And in fact, I've been involved in a group that provided ART without any monitoring when it wasn't possible to underground communities that were on the Burma or Myanmar border early on. And those patients did incredibly well, really incredibly well. The biggest barrier for individuals to get ART has been denial and stigma. And we just need to face it. This is part of the human condition. Denial is so common. I remember speaking to a truck driver in southern India who had HIV and tuberculosis. He was being treated successfully. I said to him, "Why did you not get tested earlier when you had the opportunity?" And he said, "You know, if when I get tested and I find out I have HIV, I begin to die. So I would rather not know." I understand this fear. Fear and denial are normal. They are common. In fact, doctors, we are terrible deniers. You know, we don't want to admit when we're sick at all. It's just part of it. So this is not being a denier. Denying is not because we're not a good person. It's natural. But in the medical profession, we can do so much. If we treat HIV testing the same way we treat a blood count, the same way we do a malaria smear, the way we would check for tuberculosis, our patients would agree. And that would allow us to link them to treatment. And then if we can tell them that this treatment is so extraordinary and so effective that we will walk with them through this journey, the impact that it can make is just unbelievable. So our therapies are both extraordinarily effective and safe. And the biggest barrier has not been the pharmacology. The biggest barrier has been being able to welcome individuals and to give them hope. So the key really here is giving patients that hope, telling them they can take care of their grandchildren and see them graduate from high school. They can live a full life. Now, the extraordinary thing about HIV therapy is that it's also the most effective prevention that we have, which is really surprising. I think one of the greatest scientific breakthroughs was HPTN-052, showing that viral suppression resulted in dramatic decreases in viral transmission. There's been a lot of people call this U equal U, meaning undetectable means untransmissible. But being able to get the viral load undetectable has really meant that we stop viral replication, we don't see any development of any resistance, and we do not see transmission, which is really staggering. I mean, this has been an amazing thing. We've all looked for an HIV vaccine for 30 years. Really, it's been a total failure. So, you know, despite all that money that's been spent, all that research, no go. No vaccine has really been effective at all. On the other hand, if every patient with HIV in Pakistan was taking ART, that would be as good as a vaccine because there'd be no further transmission. Hard to believe, but it would be quite extraordinary. So our goal really in this whole collaboration, our goal as providers and as leaders is really to transmit that hope, to give that hope. It's not easy, but boy, it's a great challenge to face together. Thank you so much.
Thank you, Dr. Flanagan. It was really nice and excellent presentation. And we will have you in the panel for later questions. Now, let me invite our chief guest, Dr. Faisal Sultan, who is the Pakistani infectious disease physician and trained and was here in Washu, St. Louis, Missouri, before he went back to Pakistan and joined Shaukat Khanum Memorial Cancer Hospital and Research Center. And he became the executive director and served there until 2020. He was appointed as the special assistant to the Prime Minister on National Health Services in Pakistan in August of 2020. He is going to tell us about HIV situation in Pakistan, where should we focus, and how healthcare system reform will help them to help stem the expanding epidemics. And that's would be a great way forward and a kind of a timeline and goal-directed activity for the team and collaboration between Pakistan and the US and Canada. So Dr. Faisal Sultan, please go ahead and tell us about it.
Thank you very much. Well, first of all, great listening to all of you, and very grateful for the invite. My association and connection with the HIV global story is in its timeline is very interesting, in that many of us of our generation and cohort encountered this as an incurable disease. I arrived in the US in the summer of 1989 as an intern, and HIV then was virtually a death sentence. We had one medicine, monotherapy, unbelievable today, but that's what it was. And that was what was used at that time. In fact, this continued all through my residency and all through my fellowship years. In fact, during residency, I'd say at least a third of admissions were HIV and its complications. And I came back in 1995, and having left a lot of my people, my patients through clinic, inpatients, etc., suffering through this disease, which really no one could improve other than just treating opportunistic infections. I returned back exactly a year later to attend one of our primary infectious diseases meetings. And it was as if the world had changed. All those that were dead or dying and near death started to reverse. It was almost a scene out of the movies. So my personal journey has seen this, and within Pakistan, then we saw a similar transition as more effective therapy became available. Back in the mid-90s, it was available elsewhere, but within Pakistan, it was prohibitively expensive, and we saw a turnaround of that when some of us got together to make centers for HIV care. So a little bit about that in a bit. So Pakistan, like many developing countries, has numerous health challenges and societal issues that relate to controlling the spread of HIV. Now, these, of course, and COVID-19 recently hasn't made things any easier, but it's actually given us a lot of opportunity to retool and to find methods and opportunity in adversity. And I really truly mean it, and I'll share some thoughts with you on this. Now, where do we stand today? As best as we know, we estimate the prevalence or the point prevalence of HIV based on sizes of various at-risk populations and the prevalence within them. So, for example, if we were to look at MSM, so the estimate of the population in Pakistan is 800,000, and 3.5% of them are supposed to have HIV. So that's the prevalence in that group based on data on samples, and that means that the total number is about 30,000 for the country, and so on. So this number varies as high as those with use of injecting drugs, a 38% point prevalence to as low as 2.2% in female sex workers. And these are very telling statistics, and we'll talk a little bit more about it. So some of the key issues have been already highlighted and spoken about, but I'd like to really throw some light and focus and special focus on those areas where we think the biggest problems are. If you look at some of the outbreaks within Pakistan, they are highlighted. They stand out by the contribution of those in those outbreaks that are not necessarily in an age or a group that would make sexual transmission the likely scene. So iatrogenic transmission, we feel, is at least half of the story. Injecting drug use, perhaps about a third, and in some situations, both these pathways are in effect. As far as these so-called outbreaks are concerned, and I agree with Bushra, I think perhaps these are not outbreaks. We're just discovering what we do find where we look. And so in many of these outbreak-like situations, none of them seem to be solely attributable to sexual transmission, although certainly it's been added or it is added to the mix. So fundamentally, it's been either iatrogenic or injecting drug use. Now, unsafe healthcare practices, poor infection control. We've talked about multiple outbreaks. 5 out of the 7 major outbreaks have had at least this as the major contributing factor. Jalalpur in 2008. Jalalpur, I had the opportunity of seeing virtually all of the the initial detection was 88 patients, but eventually we ended up seeing over 200, 250 individuals. And so we saw what it did. And fortunately, just around that time, the availability of effective HIV antivirals was becoming a feasible option. And so many of these individuals have lived to tell the tale. Now, the other problem is the high use of, so it's not only that it's the setting is iatrogenic, but that compared to the rest of the world, we seem to like to have a lot of injections. So the number of therapeutic injections that a Pakistani uses per year is significantly higher than the global numbers. And there are some extrapolations, but nevertheless, it seems like 1 in 3 persons might receive an unsafe injection every year in the country. And so all the strategies that we need to come out with have to actually address these and address these unsafe injections and so on. So the policies and procedures, teaching, training, funding is crucial. So far, in terms of national strategies, we've depended a lot on a global fund and other external funders, which is fine, except that when the country does not put its own money on the table, the seriousness that is expected out of implementation often goes lacking. And as we just mentioned, we're living in today's world where even in very limited settings, good effective treatment is available. It's cheap. In Pakistan, it is free. And I can tell you that all those people who remain reasonably adherent to treatment remain free of advancement of the disease. So this is really the cheapest way, not only to take care of the individuals, but also as a method to prevent further spread of the disease. So at the present time, we've got about 49 antiretroviral ART centers with 45,000 registered HIV patients, but only 25,000 of them are on treatment. So here's the dilemma. You heard from the previous speaker, this therapy, once on board, essentially acts as a preventer as well. But we are only able to get just over half of our people on therapy. And I can tell you that this number has increased very significantly. Until 2 years ago, it was even lower than this. So this is one of the issues. Anyway, these centers do provide registration, HIV testing, treatment, counseling, and of course they track loss to follow-up, etc., and do viral load testing. Of all the disease-specific vertical programs, I can tell you that this has been a pretty good program with a lot of acceptance amongst the population. But the only thing is, what's been highlighted earlier as well, to get everybody in. So if we have 50,000 people registered approximately, we are clearly missing out another about, at least 50,000, perhaps more. And so if we do not attract them, then we are missing them out. And the primary reason is what was mentioned already, that the perceived stigma and the fear of marginalized people who do not even have the confidence of coming in and thinking, well, we'll be treated reasonably, contributes to this. That brings up the importance of community-based organizations that actually deal with key populations, and they have registered, nearly 85,000 MSM, 34,000 transgenders, around 20,000 female sex workers. So they've got a reasonable arrangement on how this works, but nevertheless, a lot more needs to be done out here, because without this, you're not going to be able to reach those key special populations for whom it is not so easy to just walk into a hospital with confidence and say, well, we'll get care and treatment with dignity. There are some interventions at the primary healthcare level, which we are trying to put together as part of a universal health package. I cannot go into too much detail into this, but unless that is done, really, a lot of the other interventions, including HIV, will not help. Dr. Bushra laid out the fundamental directions of the first, second, and third strategic frameworks, and though they moved from initial sort of detection and prevention to interventions in key populations and eventually into HIV treatment and care, especially as 0 = 0 became well established. Although I think some of us in this world of HIV care knew this, or at least intuitively and eventually through experimental evidence quite early on. So there are important challenges as well. So stigma, we have mentioned. The changing demographics of HIV patients is a bit of an issue. So this FSW population used to be a fractional number. It used to be about 0.2, 0.3%. It's gone up to 2%. And the inaccessibility of some of the special populations, especially people like the transgenders, the hijras, and so on. We have a fairly large number of people lost to follow-up, and that's something that needs to be done. Governmental spending, I've mentioned already. And the other thing that we have not been able to do, embarrassingly, and I intend to do this, this is a little bit of a personal venture for me, is to get OST initiated, and opioid substitution therapy. Some of our narcotic control organizations get very jittery about this, and we're going to use our present reach and influence into the system to hopefully change this. The reuse of syringes, perhaps up to 30% or more in primary care or general practitioner settings, is, I think, at this time, one of the main drivers of this outbreak. So going forth, we really need to increase spending, and you will see this coming out of PC1s and increased allocation in some of these programs to prevent harm and reduce HIV, hepatitis, and other things. And all these, as you know, are cross-cutting. Reduction of stigma is crucial. And as was just mentioned, I think this has moved from more a biologic problem to a behavioral science problem. And I think this really needs a sociologic and behavioral approach to it. One crucial area that we really need to address is unsafe injections and blood transfusions. And we have therefore this year, you may have heard, but as of this year, after the first quarter, there will be only auto-destruct syringes that will be imported in. And after the summer, only auto-destruct syringes will be manufactured locally. So we are transitioning from reusable to auto-destruct syringes, and we do feel that this will have a significant impact into sorting this. Lastly, we've redone the National Institute of Health. The NIH Pakistan has existed for decades. We've changed the act through ordinance, through an executive order. We've actually got the act right now currently being navigated through the legislative framework. It has a completely new private sector board with only 2 governmental representatives, 7 top-line professionals from public health, epidemiology, infectious diseases, research, and so on, to lead this, and with additional funding. It has a new Center for Disease Control, which of course will be crucial in controlling many of these infectious diseases. And in fact, one of the institutes is the National Health Data Center. We've living in the times of COVID, very briefly about this, it hasn't helped to have one massive challenge of once in a century challenge, while we're still struggling to deal with many of our usual challenges like HIV, like polio, and so on. But I think one of the things that has helped us is to be able to have a data-driven, focused, coordinated response to COVID. I really think that we are in the midst of our, well, we in our third wave, which seems to be coming down, at least in the northern half of the country. And so I think any success so far, and we say this with great humility, but any success so far has been because of a lot of coherent, data-driven, coordinated response. And I think as we ramp up our vaccination campaign, hopefully we'll see the end of this at some point or the other in the next coming few months. So I'll stop here. HIV remains a serious challenge for me as an infectious diseases physician and as a practicing until a year ago, practicing clinical infectious disease doctor. This has been something that is close to my heart. And I do feel that we do have the opportunity to really turn the numbers around, which haven't happened so far. And I've shared with you some of my thoughts on what the strategies are to be. I'll stop here. Thank you very much.
Thank you. Thank you, Dr. Faisal Sultan. I know most of us know your solid track record of sincerity and success at Shaukat Khanum, and we hope and pray that your current role will bring those kind of changes, as you mentioned, for Pakistan healthcare. Now, we have some time for comments, question and answer, and I see that most of the panelists have been introduced, but I see that Dr. Zulfikar Bhutta is here, and Dr. Zulfikar Bhutta is the director, co-founder of Global Health Department in Aga Khan University in Pakistan, as well as Women and Child. He is in Sick Child Toronto, in Canada, based there, but obviously in Pakistan, he plays a key role in global health and different, and he's also the member of Pakistan Prime Minister's Task Force and all these Higher Education Commission and NIH, and he's been helping the Pakistani counterpart in leadership. So Dr. Zulfikar Bhutta, please give your comment, and I see your question about the investigations and the risk factors. How solid is the data? Please unmute yourself and give your comments for 3 to 5 minutes.
Thank you very much, Shahid. I wasn't expecting to be called. I actually just wanted to be a fly on the wall today and listen to many illustrious colleagues, and especially those who work in this field, Bushra and Faisal. And Faisal, just to correct one thing, did I hear you say that you stopped practicing clinical medicine a year ago? I don't think you have. I think you've just changed the scale. So you're practicing real clinical medicine at scale, which is public health. So we're very grateful for your agreeing to steward and shepherd the Ministry of Health. I will firstly, let me say that I am not a subject expert, but as someone who engages in public health in Pakistan quite intimately, I mean, this whole issue of HIV awareness and our ability to investigate quotes unquote outbreaks, which I do agree are not necessarily outbreaks, but are things that have been happening in the background that we're only just beginning to be aware of. This whole issue concerns me a great deal. The reason I raised the question in chat on our ability to systematically and authoritatively investigate these is fundamental. And I'll give you one example, and I'd love to hear from Bushra also. So the Ratudero or Larkana outbreak was investigated when it happened a year and a half, 2 years ago, or a little more. And it was investigated by a WHO group. And it was also investigated by a group from AKU. And some of it was published. But the most authoritative case control evaluation or assessment of why we had such an extraordinary clustering in children was never really unraveled. And part of that was the design of the evaluation. So some of us who come from a background where you ever see a clustering of such cases in children with one or two pediatricians at the center of these clusters would have liked to see a lot more robust investigation getting to the bottom of the iatrogenic or non-iatrogenic nature of this. And in addition to the reuse of syringes, one thing which is very common in rural Sindh, and I thought might come out but didn't, was principally the IV cocktails that are administered frequently in the summer, glucose infusions or saline infusions or infusions of vitamin cocktails, which are also lethal in terms of transmission at scale. So my point in outbreak investigation was very simply related to what Faisal said, which is that with a revamped National Institutes of Health and its disease surveillance capacity, which I hope will be much more than just antimicrobial resistance and polio, we ought to be able to have SWAT teams, our own national SWAT teams from the Centers of Disease Control, which ought to be able to go and evaluate those things in partnership with provincial counterparts. Now, not everything can be clustered at the federal level at the National Institutes of Health, and therefore the hope is that every province will have a counterpart and something that works very closely in tandem with the national institutes in terms of disease surveillance, of which infectious disease and outbreak surveillance would be critical. If there is one legacy that we may get out of the COVID response, and Dr. Faisal referred to this, and I will very strongly underscore the importance of data and the importance of not only data per se, but timely data, real-time information gathering, which has helped policymakers put their finger on the pulse as to what is happening. So he's able to tell you today that the outbreak is plateauing in the north and not so in the south, because here's the information. We have this information on a daily basis. Now, we are not likely to get that for every infectious disease, but I hope that as systems get established to link HIV, AIDS, TB, malaria, the kind of endemic disorders in the country, typhoid being another one, that we ought to be able to do something not too dissimilar. And that's why having these infectious disease surveillance units, which in turn can be linked to mortality surveillance in at-risk age groups, is really a vision that I think the new National Institutes of Health will fulfill. So with those comments, I'll hand it back to you, Shahid. As I said, I'm very honored and very pleased to participate, and I look forward to learning a bit more. Thank you.
Thank you, Dr. Bhutta. I returned for one very important I think comment or question from Dr. Flanagan that is clinical testing for HIV available in most settings, and somebody already answered that it's not. But Dr. Flanagan, can you rephrase your question for maybe Dr. Faisal Sultan will be able to answer or at least give us the future direction?
Absolutely. The question is really more the psychology or the medical approach to testing. I think that we've all identified the possible modes of transmission. So if suddenly every single person who ever received a transfusion in the country was recommended from the top to get an HIV test, this would have a huge impact, and every family physician, every general practitioner would become comfortable offering HIV testing. So every pregnant woman, everyone who received or maybe was in a position where they may have had unsafe injections, the approach to HIV testing would change to be something unusual or extraordinary to something that would be more routine. And that in this country has had a huge impact to destigmatize the disease and make everyone realize that it is a real possibility, even though the rates are relatively low.
Right. So, Dr. Flanagan, when the US went to opt out, essentially, is what you're referring to. Now, we haven't had that kind of a change, partly because, and you, I think, referred to it at the very end of your comment, partly because of the extremely low overall numbers. So there is the desire to actually target this a little bit more in the direction of where you're going to find gold, as opposed to a general sort of general purpose reach out. I think that But at the same time, however, we do have populations for which the healthcare system needs to be extremely sensitized to react on and pick up on. Otherwise, as you imply, the other half, at least the other half, perhaps more, will continue to get missed and will arrive late, and of course, until they get detected and until they actually graduate onto treatment and suppression, will continue to spread the disease. And those groups, I think, are well known to those in the field, in the trade craft, but really outside of that, because the common practitioners touch and feel for HIV is a few and far between kind of phenomenon. Therefore, the triggers that need to exist in their minds to test in a scenario are fairly high threshold. And so I think we really do need some methodology of making it more common. It'll help to mainstream, destigmatize, and so on. I think it's a good suggestion for us to at least tailor to our own needs. So I've just written this down. Thank you.
Thank you, Dr. Faisal. Fizza Gilani has a comment or question. She raised her hand, and then I'll also, we are about 5 minutes to, and that's going 3 minutes over the time, but last 5 minutes of this excellent program. Fizza Gilani, and then I'll ask Bushra Jamil and Dr. Fizza Rafiq for last question or comment, and then we'll close. Fizza, go ahead, Fizza Gilani.
Yeah, thank you very much. Actually, I just want to let everyone know that we were expecting Dr. Nosheen Hamad, but she's traveling from Lahore to Islamabad and she's on motorway, so she cannot get the connection. So she just texted us. So that's fine. And we will make sure that she listens to this presentation. And thank you very much. I am texting this, typing the question of the day again at the end of the chat box. So please everyone read it and send us your responses. Thank you very much.
Thank you, Fizza. Dr. Bushra Jamil, any last comment, question? How do you see any role for us, or any question and comment for Brown University or your counterpart here? What would you like to see this effort going forward? Collaboration.
I would like to thank Dr. Fizza Gilani and yourself actually to take this up with us. And I think this will be a great collaborative effort and will go a long way in training both undergraduate and postgraduate medical practitioners here in Pakistan. And we hope to make some impact on curriculum which is being taught to undergraduates here. And another important point, I think there is a will to make a change and to address the issues which we've been facing for a long time. And HIV is a big issue, and it has to be tackled now. And with the change in leadership, I think we hope for better results in the future, and we hope to curtail this epidemic of HIV in Pakistan.
Thank you, Dr. Bushra. Dr. Fizza, Zahid, Rafiq, any last comment?
Well, thank you so much. It was quite enlightening to hear about HIV epidemic in Pakistan. And my last comments will be to educate ourselves first, our medical students, and include HIV in the curriculum. We need to educate ourselves, our medical students, our house officers, residents, so that we can produce educated GPs, and GPs who are already there, they need to be educated as well. And we can involve social media to spread the awareness. HIV is not a death sentence. There is a hope, as was told already. There is an antiretroviral therapy is very important. As soon as you're diagnosed, don't think it's a death sentence, and we have to break the stigma as well. We don't have to judge people on this, so that people can come and see the doctors and get the treatment as soon as possible, because with the treatment, they can live for years and years without progressing to AIDS. That is lethal. Thank you.
Thank you. Any other comment? Dr. Timothy, any last comments before we close?
No, really great to have this panel. It's so interesting and so important, and just all of us dedicating the time. So thanks so much. Thanks to Dr. Gilani for all of her work. She's been a real champion.
Right. Any other panelists for last comment before I ask Dr. Faisal Sultan for last comment, and then we'll close. So Dr. Faisal Sultan, please go ahead. Any concluding thoughts, remarks before we close?
No, again, just thank you. It was tremendously useful to listen to all this, but I think we need to bring some action to the table as well. So we have Bushra here, who's a part and parcel of the effort here at the ministry. I know that Dr. Aisha Isani has been also involved directly with this, and I see Dr. Hassanabad Zahid, who used to be part of the blood transfusion program. So I think there are good opportunities to be able to break this cycle with the help of key directed techniques which are relevant to us and actually address the problem as it exists for us today. So thank you very much.
Thank you. With that, I again thanks the panelists and most of all the attendees. I really appreciate attendees, because without you, this program would not have been as successful, and your chat comments and your listening and your participation here on the weekend really give us hope that a lot of physicians and non-physicians and Pakistani and international diaspora members of the community are interested in this, and this gives us hope that, because it's a teamwork, it's not just Dr. Fizza Gilani or Dr. Timothy Flanagan from here, or Dr. Fizza Zahid Rafiq from Canada, and Dr. Zulfar Bhutto from Toronto in Pakistan, and Pakistani. It's a team effort. So more member and more people involved in this project, we will have more chances of success. With that, I again thank you all, and our chief guest, Dr. Faisal Sultan, for attending. Stay safe and sleep well. Thank you. Assalamu alaikum.